Morning, everyone. I'm a director of strategy at California Institute for Behavioral Health Solutions. The mission of CIBHS is to support behavioral health payers, provider organizations, associations, and oversight entities to improve the quality of care in California. We accomplish this through the implementation of innovative practice improvement, delivery system redesign, and evaluation strategies. In order to increase the effectiveness and the quality of our support in the field, we're rapidly transforming many of our improvement offerings to virtual environments. I'm really excited to be able to introduce today's presenters. We have Jennifer HALLMAN, LCSW and MPA, as well as Richie Rohde, PhD. Jennifer HALLMAN is a licensed clinical social worker for the County of Los Angeles Department of Mental Health. She received a Bachelor of Science degree in Public Management and Criminal Justice and a Bachelor of Arts degree in Psychology from the University of Arizona. She went to a dual master's program, and she has a degree in public administration as well as social work from the University of Southern California. Jennifer entered the field of social work serving nonprofit agencies as a case aid volunteer and visitation supervisor for Child Protective Services in Arizona. Later, as a social work intern, she worked with victims of gender-based harm at the USC Center for Women and Men with clinical policies and procedures under the Office of the Medical Director at LCSW. After she received her master's, she worked for Edelman Children's Mental Health Clinic and then for the Edelman Adult Mental Health Clinic for 4 years. And there she provided assessment, therapy, and case management services to clients with severe emotional and behavioral mental health issues. She's been working within the Quality Assurance Unit of LCSW for the past 12 years and has overseen the policy and technical development team for 5 years. Within this capacity, she's become a recognized departmental expert on Medi-Cal documentation, claiming practices and training, QA-related policies and procedures, mental health procedure coding, the electronic record, and the management of clinical records. You can see why we wanted her to present on this topic. And then with Jennifer is Dr. Rubio, and he's worked as a clinical child psychologist, a play and expressive arts therapist, a researcher, program evaluator, statistical consultant, and associate professor. He works in a variety of clinical and academic settings, including universities, pediatric hospitals, community mental health settings, schools, and research institutes. He's worked in 3 different countries, the Philippines, US, and New Zealand. Born and raised in the Philippines, Dr. Rohde immigrated to the US 15 years ago to pursue his doctorate through the Ford Foundation International Fellowships Program. He completed his PhD in clinical psychology at the California School of Professional Psychology. Currently, Dr. Rohde is the Director of Practice Improvement and Analytics at the Children, Youth, and Family System of Care Behavioral Health Services at San Francisco Department of Public Health. In that role, he plans and coordinates a clinical practice improvement and research evaluation program. As the former lead evaluator for the San Francisco Department of Public Health, he's helped to develop and implement a data reflection to innovate and vitalize effectiveness, acronym DRIVE initiative, that encourages clinicians to routinely reflect on data outcomes of their clients in order to improve their clinical effectiveness. He is also a research faculty and fellow at the Rockway Institute. There, he works on projects related to psychosocial functioning of gay fathers and their children born through surrogacy, and mental health outcomes of same-sex couples following legal recognition of their relationships. So 2 incredibly wonderful speakers, and I'm excited right now to turn this over to Richie Rubio.
Hi, good morning, everyone. Thanks again for CIBHS for sponsoring this much-needed webinar series. And just a correction, with my name, it's Rubio, R-U-B-I-O is my last name. But just to start, I mean, we are here in the pandemic. No problem, Robin. We are here in the pandemic right now, and it's a crisis. And when we think about a crisis, we often hear that it has its own share of like danger and opportunity. So when I think about telehealth as well, I mean, a lot of our clinicians like working with me or clinicians that I supervise often talk about the difficulties around like telehealth. But at the same time, we also want to acknowledge that in using telehealth, there are also like opportunities or strengths around it. So for one, like we notice like with telehealth, it has increased or augmented access, and it has promoted really like health equity. So when we think about like clients who come from marginalized or underserved populations, like a lot of them before shelter in place and before this pandemic could not access services because of issues around like transportation or issues around being able to balance or manage their time around like work and childcare, to be able to accommodate time for visiting a clinic and talking to a clinician or getting services from a clinician or a provider. And but now, because of telehealth, there's greater access to reach like underserved or marginalized populations. At the same time, it has increased like engagement among like clients. So, for example, where I work in San Francisco, one of our programs mentioned that prior to the shelter in place, the rate of like no show was around like 30 to 40% among like clients. But after shelter in place, suddenly it dropped to like around 14% in the last month because now clients are like easier to reach, and so opportunities for no show have really like dropped for a lot of clients. Also, another strength for telehealth is really connecting with clients in their more comfortable settings. Like a lot of clients, if we think of like health equity, a lot of clients from underserved populations hold still a lot of stigma around like mental health services. So for them, like visiting a clinic is very they hold a lot of fear or anxiety around doing it. But now, given that they are in the comfort of their homes, they can easily access services more. At the same time, it offers us a window into our clients' lives. Before, in a clinic, we would do assessments or care plan in such a way that we are trying to imagine, to contextualize how are our clients going to implement this in their home. But now it's like doing like a home visit. In doing assessments, we see the context of how our clients' presentations or needs are presenting within their home. We get a glimpse of like family dynamics because sometimes if we are in a video conference or even in a phone call, we hear clients family members around like interrupting sometimes, or we see family dynamics at play, and it's a good way really for assessing that because now we see the client in their natural environment, and it's really something that would promote or it could be viewed as like a strength of the assessment. Next slide, please. But at the same time, thinking about crisis is like danger and opportunity. With telehealth and using it for assessment and care planning also has its set of challenges. A lot of clinicians talk about it's more difficult to really strike or strengthen therapeutic alliance with the client or join the client or even like convey empathy to the client. Because it seems even with a video conference platform, there's like a wall, like an invisible wall between you and the client. So it doesn't become natural to really join with the client or even like promote like alliance with the client that way. At the same time, it limits access to some nonverbal information, which is really important for doing assessment. Like for me, when I see a client in person, most of the time I would do like a body scan as I'm asking questions. And sometimes some questions are anxiety provoking, and I see in their body how they really express their anxiety, with hands moving, sometimes trembling in their knees, sometimes sweaty palms. You could feel their breathing that way. But now with telehealth platforms, sometimes we don't have access to those nonverbal information. Or when we think about like SUD assessment, sometimes with clients, the sense of olfaction is really important in doing assessment. When a client comes in the first time, are they intoxicated? Have they used drugs prior to a session? And we get to see that in person. But now through telehealth, through video conference, we may not have access to those types of information because we're in a phone with a client or we're using like a video conference platform. Also thinking about like health equity, it's really a challenge. Many of the families we work with talk about, yes, video conferencing is great, but then in our home, we don't really have access to the internet or to Wi-Fi. We don't have a reliable laptop to use for like a Zoom session. Or with our phone, we have limited data to be able to even endure or have like a phone call with a therapist. So a lot of those we really have to think about as challenges from a health equity perspective, like even access to telehealth platforms may not be comparable to many different populations, especially those who are underserved or in marginalized populations. Technological issues are there. So therefore, this really calls for like flexibility on our part to really think about when you're doing like assessment processes, how would it look like in a video teleconference? How would it look like if that fails and all I have is like a phone call with a client? How do I flexibly innovate it or adapt it in such a platform? Privacy and confidentiality is also an issue. Like when we think about like clients who are from underserved or marginalized populations, low SES, or certain populations wherein they have limited sense of privacy in their homes to really conduct like a telehealth session. How would we maintain privacy? And sometimes we may ask a client, wear a headphone or secure a space in your home where you could really be free from distractions from your family. Or if not, is there a way to walk like further away from your home to conduct a session to maintain privacy? Sometimes you can be very innovative in ways you could delegate like a spot in the home. Like I was in a conference, in a webinar like 2 weeks ago on PCIT, and they talked about like for kids laying like a blanket on the ground and designated and let the kid know that this is your space for doing therapy with your clinician or doing an assessment, and you would stay in this space as a way also to maintain that consistency with the client. And of course, it's really important to think about safety or risk assessment. There are challenges in doing telehealth as well. Before in person, when we do risk assessment, we know exactly where a client is. But if you're now through telehealth, if you're just in a phone with a client, you don't know exactly where they are. And if you're going to do like safety planning or refer them out for like emergency services, you are not sure how to really marshal or coordinate like services to take them to emergency services. It's always important to always plan beforehand to know where your client is. And if telehealth platforms fail, know what's the best way to contact your client. Is it a phone call? Is it through a cell phone from a close support person like a family member or an intimate partner? Is it through another phone number? Or is it through text or through a chat box or through an email? Finding other ways to reach your client should be planned beforehand. Next slide, please. And I think as a way of grounding too and to anchor when we think about like assessment, I often go back to Bruce Perry's 3 R's model of neurosequential therapeutic model. Wherein really in doing intervention or even assessment with client, we have to think of how we are appealing to these 3 brain areas in terms of a neurosequential model. Find ways to regulate a client first, then relate to a client in a way that really promotes a therapeutic alliance before we appeal to their reason. And the reason I'm bringing this is if we think for a second about our assessment processes and our care plan processes, a lot of them really appeal to reason, which is really our higher cortical functions. And it's a lot of like structured questions, like interview questions with a client based on the DSM. It's a lot of planning, but they are still verbal in form. And we think about this crisis right now, a lot of our clients are very isolated. A lot of our clients are dysregulated given this crisis. And really, we have to go back to the baseline. Look at assessment and care planning also as opportunities to regulate and relate to the client before even doing our assessment and care planning processes. Next slide, please. So when we think about virtual assessment, it has to be client centered. For one, we think about assessment as a way of storytelling. John Lyons, who is the proponent of the CANS and the ANSA, I'm sure many of you are familiar with it, especially in California, given that with the children and youth system of care, the CANS is now the mandated or required functional assessment tool. And with John Lyons, I would go back to him when he thinks about assessment. It's a storytelling venture. It's a way of gathering the story from a client in a way that they walk you through their life in terms of their needs and strengths. At this time, I think we have to really think about not not generating like a long drawn assessment in terms of like a developmental history, but narrowing our focus to really what's essential to meet the needs of a client. If you see that image right there on the right of the screen, it's an ambiguous figure. And if I ask you, what do you see? Some of you may say, I see a tree. Some of you may say, I see a monkey, a gorilla, or a lioness. Or some of you may say, I see birds. Or some of you may say, I see the savannah, yet you see both figures. This is very similar. I use it as a metaphor for thinking about like assessment. Sometimes, depending on the needs of the client, we really have to decide what is foreground and what is background information. We have to think of the needs of our client in terms of what is imminent right now that we need to target for assessment and care planning versus those that can stay in the background at the meantime. At the same time, make our assessment trauma informed instead of over focusing on deficits or the needs of the client in terms of what's wrong with the client. Really think about what happened to the client, especially now with COVID-19. This pandemic or this crisis has really intensified and precipitated and predisposed a lot of clients to presentations of anxiety or depression, sense of isolation, or even like trauma. And it's important to think about that in terms of a larger context of doing assessment. At the same time, also rely on the power of observation. This can be limited sometimes when we think about like phone types of assessment or care planning with clients. But I go back to the model of Greenspan when he thinks about like observation. Even when you're in the phone with a client, then you get to hear beyond what they say, get to be very observant of how they are saying words, slurs in the words. Are they, do they have like inflections in their voice in terms of like pitch? Are they sluggish in terms of how they are saying things? Because that can really identify to you as well what's going on with the client. Another is how they tell stories. Like, for example, Greenspan talked about sometimes for clients who have some dissociation, their storytelling can be very fragmented. But then for a client who has a more secure types of attachment or are more cohesive, they tend to be more cohesive in the way that they tell their stories. So telling stories that matter, once you observe it, is also a way of doing assessment. And I think about like multiple sessions. I've heard this recently, like for clients who use Zoom or any other video conference platform. There's now this concept or construct of like Zoom burnout, being on screen for like a long time, especially like doing assessment or like care planning. Think about, is there a way to divide sessions into multiple sessions? Wherein it's only like 50 minutes, 15-minute sessions instead of the usual like 50 or 50-minute sessions. And I know now in California, the clinicians, for example, like in our system, are able to bill for services that are less than like 16 minutes. So instead of like one 50-minute session for an entire week, dividing the sessions into like three, 15 to 20-minute sessions across the week. And it's also a good way for checking in with a client like consistently or on a consistent basis. And if there's any instance of burnout, again, going back to that brain development way of like looking at intervention, finding ways to help your client regulate, probably have like breathing retraining breaks in between like assessments, or having like multiple breaks, which talks about like progressive muscle relaxation in between like assessment. It's really important and it's very client centered. Next slide, please. Of course, when we think about assessment, I think primary in doing assessment is really assessment for risks and assessment for any crisis in the client. If you're thinking about like suicidality, SAM says safety, safe dash T. And I think I shared it. I would be sharing it as one of the resources later on. It should be forwarded to you by Jennifer Clancy. With safety, I feel it's a really good summary of like a risk assessment around suicidality because it captures like risk factors, but also protective factors in a client. And also thinking about if there's a plan, there's an intent, and if there's access to like lethal means for like clients. Especially now with COVID-19. So most recently, I was looking at statistics, and there was really a compounded increase in sales of guns and firearms, like almost like more than 700% in the last month. And at the same time, when we think about when people were first sheltered in place, like going to like grocery stores or pharmacies to stockpile on like medications. Again, when we think about this in the context of like access for clients, for access to lethal means of like attempting suicide, we can think about this well in terms of the COVID-19 impact. Also, when we think about health equity, it's important in our assessment to have like cultural risk assessment. Certain populations right now, based on disparities in COVID-19, we can think about some race or ethnic groups have experienced a lot of discrimination, oppression, aggression, even microaggressions because of belonging to a certain group, which has been tied to the inception of COVID-19. That's important to how that could be a precipitating event for certain populations like Asian and Pacific Islander populations who are really taking the brunt of a lot of this oppression right now, whether it's a cultural risk for why they are presenting with certain risk behaviors. Increasing clinical contact is also important, like doing like check-ins with the client, like whenever you do check-ins with the client, if it's multiple sessions throughout the week, always doing like a risk assessment at the beginning of each session is very important. And also part of the assessment is also identifying individuals who would uphold the client's safety that is available right now at their home or virtually. Sometimes now, due to restrictions around like physical distancing, clients may not have easy access to people who could really secure their safety. So getting from the client or people you often call to or FaceTime with, throughout the day, am I able to contact those persons and then ask the permission of the client whether they would allow you to contact those persons, and then you could help them do a safety plan for the client so they can check in on the client many times during the day to ensure their safety. One model that I would recommend is the CAMS, or the Collaborative Assessment and Management of Suicidality by Dr. Jobs. And they have a website called CAMS as well. And with that, if you see there the visual or the image at the lower right-hand side of the slide, you see there a therapist and a client side by side with each other, which for Dr. Jobs is a very powerful way for really doing like suicide assessment, because you are there with the client side by side with them and collaborating and really making sense of the risk of a client's risk. And I think with telehealth, this is more difficult really to simulate or to do or to implement. But I've recommended sometimes for some clinicians, like here, I feel there's still a hierarchy when I'm right across you in terms of doing assessment. But if there's some way, for example, to lean on the side sometimes as a way to acknowledge, or, if you're using, for example, an assessment form, like looking at it side by side with the client, as if you were seated right next to the client, they feel that may strengthen that sense of collaboration with the client as well. Next slide, please. For safety planning, this is not something I would delve much into because this is an upcoming webinar, I think, with Dr. Dempsey in early June. And really, when you think about like suicide prevention intervention, we have to find ways to do like safety planning. There's one here that I really like by Pacheco, wherein in the middle of that safety plan are really the three most important things to consider: emergency numbers, support people to contact when one person is in crisis. And when we think of like support people, right now we have to think about virtual social contacts or virtual supportive people, people that a person can contact through, through Zoom, through the phone, or through FaceTime, that, especially when they are distressed. And then also thinking about like protective factors, what are things within themselves that can help them through the crisis. And also when we think about social activities, think about like virtual activities, especially right now with physical distancing, the client can engage in. Next slide, please. Also, thinking about assessing for risk, I think it's really important to think about not only suicidality, but also child maltreatment, intimate partner violence, and then family violence. And in that slide, I show there like a couple of resources that you can go to when you're looking at how it's different now with COVID-19. So, for example, in assessing for intimate partner violence, a lot of using like power and control over one's intimate partner sometimes strengthens that sense of isolation in clients or potential victims of intimate partner violence because of misinformation around COVID-19. And now that prevents a person, for example, from contacting family, from visiting family, and that could really intensify the risk for intimate partner violence in the home. Next slide, please. I think it's also important to think about when we think about assessment, the past 20 years talks about therapeutic assessment and collaborative assessment. I know from a billing perspective, we need to separate how we view assessment versus intervention and that they are billed separately. But in reality, when we're doing assessment, it's really a form of intervention already. It is a way to really promote positive change in the client, and it's an opportunity to promote positive change. Like how we sit with the client, asking them questions. It's not a matter of just giving them like a screen, like for example, a back depression inventory for them to self-report on and return back to you, but having a conversation to understand the client's story around their symptoms or their presentations that way. Next slide, please. For the next parts, I'll just share some of the tips that I have in terms of like thinking about assessment. So for example, you can use like bibliotherapy as a form of assessment. One that I use with kids, for example, are books like A Terrible Thing That Happened. It's a story of a raccoon. It doesn't tell you what terrible thing happened with the raccoon, but then a lot of clients, or a lot, especially children and youth, can relate to this. They can visualize what for them was a terrible thing that happened. But in that book, it gives you the different presentations of the raccoon because of that terrible thing that happened, like having nightmares, being angry every day. And then also with Piplo Productions, which is another website I would go to for bibliotherapy. Most recently, they came up with a story called Trinka and Sam Fighting the Big Virus. And this is really the story about a family as they're navigating their stresses and joys of being sheltered in place with COVID-19 crisis. And in this books, it gives the flavor of what are the different experiences of kids and youth and families around this pandemic or around this crisis. And later on, you could ask a client, is that your same experience? Have you experienced any of that? And they can tell you, oh, yes, I am just like that raccoon in that terrible thing that happened. I'm having nightmares. It's a form of like normalizing the presentation of clients in a way that many kids like you or many youth like you experience the same things. It's a way of making it typical as a typical experience for clients. Next slide, please. Other ways you could use, I would go if you are doing play therapy with kids, you can go to like Tammy Van Hollander. She has a YouTube channel wherein ever since day one of being sheltered in place, she has been disseminating telehealth ways of doing like play engagement with clients. I also shared with you a handout from Lowenstein, who is a child therapist, on how to engage clients around like assessment. And sometimes with assessment, we can start with like establishing rapport. Like with a lot of kids I work with and clinicians that I supervise talk about it too. The first time they do assessment, sometimes it starts with kids with show and tell. They want to show you everything in their home, their dogs, their cats. They want to give you a tour of their house. That's very important for like doing assessment because you see the natural setting come alive for that client and you know the context of their presentation. But at the same time, as a way to help a client regulate and increase relating as well, consider nonverbal expressive experiential activities to like assessment. One thing that I use, for example, is like using like visual analogs. Or I do also use like SANDTRAY with clients. Sometimes I'll give this an example and I'll show it. I would use like a sand tray. So I will become like the hand of the client with a sand tray. Like depending on what the client likes. For example, for this client, he's 8 years old and he really likes sea creatures. And I use like sea creatures that vary in size as a way for him to assess how big is his sadness or how big is his anger. Is it as small as an orca, a baby orca, or is it as big as like a humpback whale? And it's a way as well to make your telehealth session with a client interactive when you're asking like a scaling question and then using like miniatures, like Sandra miniatures to help a client really scale their emotions or their thinking or feelings at the moment. You can use expressive arts, like some video conference platforms have like whiteboard. Clients can draw on them, can express to you what their world looks like right now. Another thing I'm looking when you are assessing for like family dynamics, we are more familiar probably with family genograms like Goldrick, with the circles and squares and the lines drawn on like a sheet of paper. You could also do it like through like a sand tray. So is this something I used to? If you have like a sand tray, again, you become the hand of the client, ask them to choose family members, and they can tell you, okay, I have grandma in my family, and okay, I can pick that miniature as me, and then I have my mom in the family too. Oops, sorry, that fell. And then in the family too, there is dad, but dad is so far away. And the client will tell you, okay, can you put dad at the very far end? And you could ask questions like, what's going on there? Why did you decide for the dad to be in the very far end? Well, dad is not present all the time. So in here, using like a family genogram through play or Santra is a way again to assess for like family dynamics with a client. And then they can create it with you collaboratively through telehealth. And then you have the platform, the Sandtray with them. But of course, they don't have a Sandtray with them where they are, but you will be their hands and you could show it to them through a virtual means how they can do their Sandtray. Of course, puppetry is another way. You can help them design their own puppets and you could do assessments that way. Next slide, please. Of course, in assessment, we have to be strength-based, things I've done with clients to really reinforce their sense of strength is like creating like a self-introduction collage with materials they already have at home. So for example, magazines where they could cut out words that could speak to strengths within themselves. So there's one example there on the screen that you see right now. Or we can think about like assessment tools that we use. For example, like in California now, Dr. Nadine Burke Harris has been promoting a universal ACEs screening, which look at like adverse childhood experiences. But what is to balance that out, we also have to look at the resilience score. What is the resilience of the client, which could be very useful in treatment planning as well. Next slide, please. For the last few minutes, I also want to speak about like care planning. Care planning can be done. You could do like worksheets with the client. It could just be verbal. You can talk about what are the goals for the client. But things I've used, for example, if you have the ability to share with the client your screen via like a video conference platform, you can share a worksheet like this goal exploration worksheet, which has been sent to you as like a handout. Or to the right of the screen, you also see there what I have encouraged our clinicians in San Francisco to use, which is a case formulation and treatment planning worksheet. So in here, using the cans, again, thinking about foreground and background, deciding with the client what is to prioritize in terms of needs, but to balance that in terms of what strengths to build, and at the same time, what strengths to use to help the client in their care plan. And then at the bottom of it, then you collaboratively work with the client in terms of activities you could do together, in terms of to help them diminish or manage their symptoms or their presentations and respond to their needs. But be very mindful as well of like using worksheets because sometimes clients may not have access to it. So if it's like you're doing telehealth via phone, you might need to read through the worksheet and then you be the scribe for the client. Take a picture of it after you have written on the goal exploration worksheet and then send it to a client so they have a copy for themselves. Or, for some clients, if they have access to a printer, then they could print it and then do it with you in a session via telehealth. But if they don't have access to a printer, again, when we think about health equity, certain clients from underserved populations may not have access to a printer at their home. So again, be very mindful about how you deploy or use worksheets in your interventions and assessment. Next slide, please. Also, it's good to, again, the importance of choice in care planning. And I think here, I think we have to go back to the basics of like doing intervention. We're still promoting or strengthening choice within clients. For example, John Wise and Sarah Bierman most recently came up with this book on FIRST, which is a transdiagnostic principle-guided psychotherapy for children and adolescents, wherein they looked around at most common evidence-based practices and distillated it to like 5 buckets of interventions. Interventions that help the client feel calm, like relaxation or breathing retraining, those interventions that help the client increase motivation through reinforcement, those interventions that help the clients repair their thoughts, cognitive restructuring, solve their problems, and finally, trying the opposite. Like when we think about exposing clients to feared situations, or when we think about like trauma, when in the first place they were trying to avoid their trauma story, trying the opposite is now approaching their story in little steps, trying to process their trauma narrative is another way of trying the opposite. I think this is a very good way of like doing psychoeducation with a client in terms of like what works for many clients who have a presentation like you, and collaboratively with the client work with them in terms of like what would you want to work with first? Should we do a repair of your thoughts? Should we work on your breathing? Or should I give you like self-care distress tolerance skills so that you can manage like anger or distress at this time? And that could be really a way of like empowering a client to make choices about their treatment. Another way is modeling. Bibliotherapy is a good one. Usually I choose books that have a good story arc that tells you what the problem is, how do characters in the story manifest the problem, and then how do they recover? How do they solve their problems? And in that, you give the client then a whole range or spectrum of possibilities on how they make themselves better through bibliotherapy, and it could really help them that way. Next slide, please. Also, other ways is using solution-focused brief therapy, which I feel, your manner of asking questions could be a way of empowering the clients to realize their strengths and use it, like the exception question, the miracle question, or the coping question, helping clients realize that, oh yes, I've had some coping skills in the past, and really helping them design their intervention in such a way that they could leverage those coping skills that they have used in the past. Again, for regulation, nonverbal expressive care planning could be used. I've used journey sticks with clients or narrative exposure therapy, Lifeline. When for a journey stick, this comes from the Native American Aboriginal cultures. They go through a journey with a stick, and in every step of their journey, they gather objects in their environment to put in their stick to really represent their journey. Similarly, for clients, I've done this in the past with clients, children, youth, and even adults, doing a care plan through a journey stick. How does your future look like, and what are objects to represent that future? And then what are steps that we could take to reach that future goal? Uh, Next slide, please. Mental health apps is also a good one. I would recommend the website Cyber Guide so that you could choose apps that are free or accessible for clients. And you think about like health equity, and also apps that have been proven or have evidence base in terms of like really working for clients. So for example, right now, COVID Coach is one that I would recommend. It gives there a whole set of like activities that clients can use and do to make them feel better or to help them with their symptoms or presentations or their needs. And then you can, collaborate with the client in terms of deciding what from these activities would you want to do first, and then make it interactive in such a way both of you are looking at the app at the same time and collaborating with the client in terms of like working uh, on activities that would work for them. Using narratives could be another way, and I'll give an example for that in the next slide. So next slide, please. So Uh, this is an example from a client who's an adult. We're in using an app or an internet-based care plan example. So for the client, for example, he presents with a lot of stress and anxiety around the pandemic. So in helping him using an app, if you see there in your screen how to manage stress, and there are different tools. As part of psychoeducation, you could help the client know what each of them are. What is a body scan? What does it mean to have like daily rituals? What does it mean to be doing like breathing retraining? Later on, empower the client to what would you want to do first? What are activities here that you would want me to help you with to make it very collaborative? Or on the right side, you see there a web-based website for helping with anxiety and depression called This Way Up. Again, there it gives you like a whole index of like resources, and then you can help the client collaboratively decide on what activities they could use. Next slide, please. Finally, here, this is from an 8-year-old client I've had a while back. And when I asked her to do like a care plan, I asked her, what are your goals? And she's a 14-year-old, she's a 14-year-old girl. And when I asked her, her presentation is really, she experiences like traumatic grief because of the sudden death of her mom to cancer, and then now she has to stay with her dad. And prior to that, her parents divorced. So when I asked her like, what are your goals right now? She would say, I don't know. That's verbal in the language base. And then I would use a worksheet, like a goal exploration worksheet, and ask her, what are your goals? And still she wouldn't do. I went back to like a more expressive way, like a SANDTRAY, and I asked her to create, what would a world look like for you, uh, like a perfect world look like for you, or an ideal world wherein you're not experiencing this sadness right now. And she created this in her SANDTRAY. Later on, when I asked her, she really represented her goals, what she really wanted. Like, I want to be closer to my dad. She represented herself as the tiara, and her dad is like a horse. And she talked about, I really want to be closer by my dad. And then in the middle, she talked about having nightmares. I really want to get rid of those nightmares of like my mom. I kept losing my mom in my dreams, and that's really a nightmare to me. And she represented the nightmares as like a snake. And then I want to stop being angry, so she represented it that. And then last slide, please. In closing, I just want to go back to when you think about like assessment and care planning, there are really opportunities to be more trauma informed in the way we do them. If you go back to Bruce Perry's brain development model of like help the clients, even not through intervention, but through assessment and care planning, to regulate first, relate with them. It's also an opportunity to build alliance. And then before you go to assessment and care plan processes that really appeal to reason. With that, I want to pass it on to like Jennifer. with the presentation. Thank you so much for listening.
Jennifer, you may be on mute. We're not hearing you.
I was on mute. I did the thing that we all do. How many times a day do we say, oops, I was on mute? So thank you to Richie. I think it was so important that we started with the clinical part around doing assessment and care planning. That is what should be driving the work that we're doing with our clients. But so often some of the quality assurance kind of documentation type stuff tends to get in the way of what we're doing. Sorry, I was having a power cord issue with my computer. So can you go to the next slide, please? So just as a quick overview, what I'm going to talk about today are kind of three main areas. It's the safety planning, making sure you're set up when you're doing virtual assessments and treatment planning. It's the technology, having a backup plan, preparing for that like I'm doing right now with my power cord. The administrative side of what you're doing with assessments and treatment plans. And then last, we're going to get into the documentation around your actual assessment and treatment plans. Next slide, please. So around safety, I think you really, before you even start doing your assessments, you want to plan for how you're going to handle emergencies and protecting clients. Knowing, as Richie talked about, the emergency contact information, where is the client, what's their address, who's nearby to help them out, what are local urgent resources for them that you can have in your back pocket if should they need it. But also thinking about, you're not in a clinic setting, so you don't have your supervisor or somebody else to go to in an easily accessible way. So you want to think about beforehand, how can you get a hold of your supervisor when you're doing an assessment or any other service with clients, and especially with assessments, because you don't always know what the client's going to present with. So you want to have a way, kind of a thought out way of how you can get a hold of somebody to help you should something come up with the client. A couple of resources for you, telehealth tips of suicidal clients. I think many of you have probably already seen this, but it is a great document on some ideas of how to help out with suicidal clients when you're doing telework. And then also the State Department of Healthcare Services has put out information saying that you can do telehealth 5150s. The challenge with that tends to be, how do you get that application to the location that they're going to? You know, all of the logistics around that ends up being the real challenges. Here in LA, we have found we just don't have, some providers have figured out ways to make the telehealth 5150s work, but for the most part, a lot of people are just struggling and saying, this is a lot of administrative work of, you know, how do we get that form to the hospital? How do we make sure that the client got to the hospital if we're not the ones there doing it with them? And then also knowing what your reporting requirements are. How are you going to do that? Again, you're already kind of taking up your phone line, doing the assessment. So how are you going to handle some of these other areas when you're on the line with the client? Do you have another line you could go to, or another way that you could do it? Next, please. Next slide, please. So around technology, again, some things to think about beforehand. The U.S. Department of Health and Human Services Office of Civil Rights has stated that they will not impose penalties for non-compliance with HIPAA rules, and which is great because it's given us some greater flexibility in the different communication methods that we can use. For example, you could use Zoom, although I know we've all heard some challenges with that. And you can kind of quickly get up and running with telehealth. I think that some of the challenges is certainly you should, if you work for an agency, talk to your agency. Some agencies have still set up some guidelines because they really want to make sure that the privacy of clients is protected. But do know that they have opened it up so that you can use other modalities during this time. I think one of the other things to really think about is making sure that the client knows how to use and has what technology do they have the ability to access? So a lot of us have talked about, Zoom or even FaceTime on some of those methods, but that does require that the client have, certain capabilities that they can do. So as much as we might be able to use some of that, can the client use that and be prepared for what works for them? And it might happen that you need to go to just the plain old telephone contact because they don't have that capability to use some of that technology. And then always have a backup plan if technology fails or you have technical assistance available to clients. I was at the doctor's office when all of this COVID started happening, and I could hear the staff at the front desk calling clients, letting them know they have telehealth available, and then walking them through that process of how to access that application that they were using. So you'll want to think through how can we help our clients, because some of them are not going to be able to use some of that technology. Next slide, please. On the administrative side, and I will say that here in LA County, this is probably one of the greatest challenges that our clinicians have been experiencing, is really coordinating how to get some of our administrative forms completed that we do require prior to an assessment. So a couple of nice things that has come out is that the Department of Healthcare Services has said that related to consent for services, you're no longer expected to get signatures. Which is great because, quite frankly, we weren't able to get signatures when we're not seeing clients in person. So it just wasn't really doable at all. Here in LA, one thing that we have done, because even though we are having staff do verbal consent for services, so we're asking our staff to still go through our consent form and get that verbal agreement to it. We think it's important that the client understands what they are kind of signing up for when they come in for our services. But what we were finding is that staff are now at home, and we had a paper-based consent form. So even though we were asking them to just document the verbal agreement, they then still had to figure out, well, how do I get that paper form? Because I don't have a printer at home, and it's not like I thought to print out a bunch of copies before I was at home. So how do I get that form to document on? And then we require it to get scanned into our electronic record. Well, how do they do that? Most staff don't have scanners at home. So how were we then logistically handling that consent getting done? And so what we ended up doing here in LA is we created a new form within our EHR for consent for them to document the agreement from the client verbally. So that we remove those logistical barriers of getting even the verbal agreement to the consent. The notice of privacy practices and release of information, again, things that you want to make sure the client is aware of. They need to know these things. DHCS has said that you can document client consent in other ways. So I think that starts getting to, can you mail it to the client? Can you get it back from the client? We are documenting that we shared the information with the client, that they agreed to it, that they're aware of these things. And so there is some flexibility there as well. Consent for telehealth, that was something prior to COVID that had already been in regulations, that you had to get written or verbal agreement from the client to do telehealth services. The governor put out an executive order saying that verbal and written agreement consent is no longer required during this time. So I think that really helps to remove some of those administrative barriers or things that we were having to do beyond just doing good clinical services, is we were having to do all these other things. And so that is nice that that has been removed. Financial forms, while that's not typically something that clinicians have to worry about in our clinics here in LA, what we found is that financial forms has become very challenging because we're still having to get signatures on that. There's the least amount of guidance coming out related to those. Here in LA, the other thing that we found is that clients are a little fearful of giving financial information over the phone. And so sometimes we've had to get the clinician on the phone with the financial staff, having a three-way call with the client, and the clinician kind of having to help make the client a little bit more comfortable in giving over that financial information. So all things to kind of think about prior to even getting into your assessment. Next slide, please. So before you conduct your assessment, we strongly encourage knowing what is needed and what is required. And this goes back to what Richie was saying of, during this time, people are having kind of Zoom overload. I know my daughter herself, she's like, I hate Mondays because I have to do school on Zoom, and she's the kid that loves school. So I think a lot of us are getting where it's a lot. So asking a client to come do, a 2.5-hour assessment over Zoom or some other type of method of telehealth is really probably not very practical. So really thinking of what do you need to focus on with your assessment. A lot of agencies have some requirements related to an assessment. So knowing what those exact requirements, what do I minimally need to do in that first session to get my assessment documented? And if you know what those requirements are, it allows you to have greater focus on the client and have a very pointed conversation, go where the client wants to go, but you're making sure in the back of your mind, I need to hit on these key points because those are keys to having the assessment and knowing what's relevant. So often what we see is staff kind of gathering everything. And kind of thinking, maybe I don't need everything right now. Maybe I need to just focus on some relevant information right now to get us going. The other thing is to consider collaborative documentation. So one of the strengths of collaborative documentation, the idea that the client can see what you're documenting as you're going, is that the client might be able to follow along. One of the challenges is obviously how are you going to be able to do a split screen so that you can see the client and also see your documentation at the same time. And that is something actually my staff have kind of tested that out of having the client one place and then having our assessment form up another place to see, is this possible? And then how would that work for the client? Is that helpful for them to kind of see where you're going with the assessment? What information needs to be gathered. And so then it's not just that visual kind of trying to hear what you're saying, but also getting to see it on the screen. Next slide, please. So as kind of a reference slide, and I'm not going to go through all of these, but I thought it would be helpful to kind of get an idea. These are the state requirements related to an assessment. On the left-hand side of the screen, you see the specialty mental health services requirements related to an assessment. And then on the right-hand side, you see the drug Medi-Cal ODS assessment requirements. Check with your agency or wherever you work because they might have additional requirements to this. But this just gives you an idea of some of the areas that you need to make sure to touch on. And looking at like the specialty mental health services, you'll see under number 2, it says relevant conditions and psychosocial factors. And so during COVID, especially where you're doing a lot of telehealth, and you might not have that 2.5 hours or whatever it was you would normally take to do an assessment, really honing in on what is relevant during this time instead of gathering the whole everything at that first contact. Next slide, please. So when you're actually conducting your assessment, you want to focus again on what's relevant in order to start treatment, address the client's immediate needs, and determine an initial diagnosis. At the heart of it, that is the purpose of the assessment of what you're doing. And so that is, bringing focus to those elements instead of kind of all of those pieces that are on the paper assessment form or in your EHR, and kind of really focusing back on those key elements. And always remembering that an additional assessment information can always be gathered at a later time. And diagnosis can always be refined at a later time. Nothing says you have to have the exact specific diagnosis to start with. You can always go with a more general diagnosis. And then as you get more comfortable with the client, as you get more information, you could always refine it. And especially during COVID, I think that's going to be an important piece because you're going to have to start teasing out how much of this is related to what's going on with COVID or doing this by telehealth, right? That might even give a different presentation of the client because they're not comfortable with COVID. So they might appear really anxious, but in reality, they're not, that doesn't tend to be how they're presenting. It's just because of that telehealth method. So allowing yourself that flexibility that assessments can be done over time, that you can always refine it and gather additional information is, I think, something really important to think about. And then be sure to document the assessment was done by telehealth or telephone due to COVID. We give a sample template there. In our electronic system, we created templates so that staff could easily pull this in, the language already there. They don't have to type it out every time. And kind of going back again to that time when I was at the doctor's office, it was again right when everything was starting up with the safer at home. And the doctor and the nurses were all talking about what their template language was going to be for their telehealth contacts. And so I think that's just really something, if you have an EHR and you have the ability to create a template that you can pull in, I think is a really useful tool that really will help staff so that they can quickly document as a reminder this was during COVID. I think there's going to be some flexibility. There's great flexibility during COVID, people recognizing that things are being done a little bit different because we have to. And so having that template you can easily bring in will be really helpful. Next slide, please. If you're not able to gather certain information, particularly the mental status exam, as Richie was talking about, there's going to be some things that you can't observe, particularly over the phone or even on telehealth. Be sure to document why. And I think, in my role as QA, we're always wanting to say, let your documentation explain to me what's going on. I always want people thinking, does it make sense why I did what I did? And if it makes sense what you did, then no, auditor or anybody else is really going to have an issue with it. I mean, there's certain other factors that go into that, but that's just a general rule, is think, does my documentation fully explain why I did what I did? So in this example, maybe documenting due to telephone method of assessment, unable to observe client's contact, which really differentiates between the situation of, I didn't even try to document their eye contact, but here you're giving the legitimate reason of why you weren't able to get that information. Also, make sure to document where information is coming from. So consider asking other significant parties, particularly if you're doing a telephone contact, getting information from them, because maybe they have some information that you weren't able to observe or hear from the client themselves. But then making sure to document in your assessment that that's where the information came from. So in this example, per mother, client appears to be more withdrawn and isolated in the last 3 weeks. So you're being clear, here's what's going on. It's not something I observed myself, it's what the mother has reported to me. And again, Richie touched on this, is, we highly recommend scheduling a separate session after the assessment to develop the treatment plan in order to reduce the amount of time that you're on that telehealth or telephone session. And I think a lot of time, kind of pre-COVID, people were trying to get everything done, all the requirements, all in that first session. And I think now's the time we might need to step back a little bit from that process and really think of what makes sense for the client and what really can I get done and what do I need to get done during this session. Next slide, please. So prior to doing your treatment plan, you want to have a sense of the client's needs and what interventions may be beneficial, and really think about what interventions can you actually offer. And I think that one we put in there specifically because of what's going on with COVID-19. Does your agency, or are you still able to offer groups to the client? You don't want to offer something to the client that you might not be able to provide right now. So being aware of what are we offering right now, what's the method that we're offering it, and also knowing staff availability and how often staff can meet with the client. Do you have the current capacity right now to see them every week, every day? What is that? And things are a little bit different right now during COVID. So you want to think about that prior to getting into your treatment plan with the client. You don't want to get in a position where you start talking about groups and then you're going to have to come back to the client and say, oh, sorry, I didn't realize we weren't doing those right now. And also know what's needed, as we talked about with the assessment, know what's needed on your treatment plan so that you can try to simplify it and kind of focus on the clinical needs of the client and not trying to get all those required elements for the treatment plan. So if you go to the next slide, I think that should take us right into our state requirements for the treatment plan. And again, on the left, you have what's required under the specialty mental health services. And on the right, you have the drug Medi-Cal ODS treatment plan requirements. And I think at the heart of it, a treatment plan is really about coming to a shared understanding with the client of what their needs are and then what you can do to help them get better. And if you take all of these requirements and you kind of boil it down to that, that's really going to help you build a strong treatment plan for the client. Next slide. So when you're doing your treatment plan session, start by reviewing the assessment information with the client. And then something we're really trying to, we can't overemphasize this enough here in LA, is keep your treatment plan simple. A lot of times we will see treatment plans that are, it's like a paragraph for the objective. And, if I had a paragraph for my objective, I'd be like, what am I supposed to do? So you want to try to keep it as simple as possible. Again, treatment planning is about having a shared vision for what you're going to do to help the client. And a treatment plan can always be updated at a later time as services become available or as things change for the client, because things might change over the next couple of months. So we can always go back and update our treatment plan. During this time, because we're doing a lot of things virtually, one of the big challenges around treatment plans has really come up around client signatures. And so I think what we've really encouraged people to do is focus on the client participation and agreement part of the treatment plan, not so much on the signature. DHCS has again stated that they're not expecting us to get signatures. But you do have to document the reason why the client is unavailable. So this is another area where we've built out a template so we can go ahead and pull in a statement into our treatment plan. Our template, what it says is client understands and verbally agreed to the plan, but is not available to sign due to procedures in place in response to COVID-19 public health emergency. So there you get a very simple statement saying this is why we don't have the signature. But the client did understand it and they agreed to the plan that we put in place. We also require in the state for specialty mental health services, they do require offering a copy of the plan to the client. So another thing to think about is how would you actually get that copy to the client if they say yes? I think a lot of us are used to the client declining a copy of the plan, so we probably don't think about it so much. But in those rare situations where the client does say, yeah, I do want a copy of my plan, how are you going to get it to them? So do you have the ability to do a secure email to them? Are you going to print it out? Do you happen to have a printer at your house that you could print it out with? Can you go into the office? Can somebody at the office do it? So maybe you could mail it, or do you have a client portal where you could put it there so that the client could pull it down from the client portal? So again, things to think about and be aware of prior to doing it, because you don't want to get in a situation where you kind of put it out there and then the client's like, yeah, I do want it. And you're like, ugh, I haven't really thought about how I'm going to get that to the client. So doing some of these things to really prepare for it, I think are really important. Next slide. I think we are at the end. And I think I ended right on time, Jennifer.
You did perfect, Jennifer. That was great. So thanks to both of you. Questions are coming in fast and furious. And so luckily we have a little bit of time for some questions. And so I'm probably going to go back and forth in some of these. Richie, I did just want to note that a number of questions came in. This isn't a question to you, it's just a kind of heads up for clarification about some of the folks that you referred to during your presentation. And so what I'm going to do is that I'll email you after this, and we'll make certain to get those answers in our post-webinar email. So for all of you who had questions about some of the specific references to either helpful sheets or speakers or YouTube sites, we'll get those to you in our post-webinar email.
That sounds good.
Richie, here is a specific question. Can you offer some best practices for conducting assessments and play therapy in the office while adhering to physical distancing and infection control protocols?
Yes. Thank you. I mean, a couple of things I can think. It depends, of course, on the configuration of your office again or your clinic. Like, for example, for some clinics I work with, and they do like PCIT. So they have like the availability of like having 2 rooms wherein there's a glass divider in between. And you can conduct sessions that way. One, the clinician is on the other side of the glass, and the client is on the other side, and you can maintain, you can get as close to the client as possible as well when you do that. But of course, like, both of you should have like a headphone so you can really listen to each other. But if there's no option for that, there are various ways to do like physical distancing even within a limited space. Like, make sure, of course, you follow the protocol, wearing mask. And I think the main thing that will be compromised would be really speech, like difficulty like hearing the client, because you will be really literally like screaming over each other. A good thing to do, I think, would be to have, use like basic things like a walkie-talkie, or if you have access to like 2 phones, you are there in the space with the person, and that's important for building like therapeutic alliance. But both of you are on your phone, so you can really audibly hear each other in terms of that back and forth of like asking questions and responding to questions. Those are, basic things I can think of. Yeah, I'm not sure, like Jennifer, if there are other things that you have heard from clinicians in your system that they have been using.
I think those are the same things that we've heard of here, is using the observation rooms when you have them available. I'll just point out, and I think we all need to remember, we're being put in a situation where it's like nobody was really fully prepared for this.
Exactly.
We had a clinician in our system that not only were they asked to do a telehealth virtual assessment of a 4-year-old, which is not something we normally do, but they were also asked to conduct it jointly with a Kaiser therapist. So
Yes.
that is also not something that we do.
Yeah.
And people are it's really amazing watching what clinicians are doing, because they're rising to that challenge and they're just kind of going with the flow and saying, you know what, I'm going to do the best that I can. And I think that's where we kind of have to keep people, is just we keep doing the best that we can.
Exactly. And that's the most important thing. And I would, like, resonate that as well. I mean, another thing, like even working with kids, like play materials are very important. And I know one of our clinics, what they did is having like separate buckets of like toys for every kid that comes in, so that they can easily like disinfect it. Or if the kid will come consistently, they work with that same bucket through, all throughout assessment and intervention. Instead of bringing all the kids at like one space, and you would have to disinfect all the toys at the end, after every session, which is can be a lot of work.
Great suggestions. Thank you. Jennifer, this is one for you. We had a few different questions that came in related to 42 CFR. And so first one is, how do our participants manage telehealth sessions and also comply with 42 CFR?
Yeah, so I think so it's kind of going back to the HHS guidance. I would encourage you to take a look at the HHS website. I had the link there because it has information there, because ultimately it's going to come down to what the federal government is saying related to that. And I think 42 CFR, as far as I know, has not changed because of COVID. I haven't seen any changes related to that. Also, the DHCS info notice that I referenced, they are getting information from the federal government, and they're posting it into theirs. So I think, again, it's documenting, getting that verbal agreement when you can. And that's kind of going back to those items, I think, are the best things that we can do at this time.
And Richie and Jennifer, this is actually for either of you. A number of different questions came in about group telehealth. Do you have any thoughts on how to be effective offering group telehealth services?
I think one thing based on like health equity, I mean, you could do the same. You could do like a Zoom platform. And then in there, like, you could use the share function of like Zoom or any other video teleconference platform to be able to like do like psychoeducation activities with individuals. And I think like in a group, you can do typical things, as long as you have sufficient preparation beforehand to help the client and their family like gather materials before a group session. I think prep work is very important, but also be very cognizant about what platform works for everyone, because you cannot conduct a
Yep.
group wherein two members are on the phone and the others are on video.
Yep.
It creates a lot
Yep.
of inconsistency and probably paranoia, feelings of paranoia among other members who are not able to access the same platform.
Yep.
So make use of a platform that works for the entire group. I think that would be my recommendation for that.
And Jennifer, I can send you over a link. My team had created a document of guidelines for doing group and family telehealth and telephone services, and kind of walks through things that you want to let the client have, the conversation you want to have with each member of the group individually prior to conducting the group. And then also some guidelines for when you're starting the group setting. I think we've all been on conference calls where people start talking over each other, or, where people are saying things, you hear in the background. I mean, I've been on conference calls where my son has run into the room, didn't think he was going to do that, and says something, and all of a sudden everybody has heard, before I could mute myself, my son saying something, and that was probably not everybody needs to know about him. So I think I can share that document and we can get it out to all the participants, because I think it gave some very useful tips for groups of things to think about in setting, before you start the group, some key things to go over with all of the members, and setting those ground rules for the group sessions.
Excellent, excellent. Thank you. I'm going to raise another question, and Richie, I'm going to related to the digital divide. And so a number of our participants are really having difficulty because their clients are having either kind of low computer literacy, there's language barriers. Do you have some ideas around how our participants can be effective despite the digital divide that's going on right now?
Yeah. I mean, one thing that I would really recommend is to slow down the process of like even doing assessment or care planning. Your first session may be just psychoeducation, like helping the client walk through the platform. And if I'm thinking about anxiety, usually for anxiety, if you expose clients to something new, like for example, a video teleconference platform, you have to have like small steps to reach that. Probably your first session would be with a telehealth platform that your client is most comfortable with, like phone. Okay, let's start with a phone conversation on our first session. Next session, we'll try a video. You walk them through the video platform, but it's just a video wherein you see each other and talk with each other. And then next session, if you use like worksheets, then you start teaching them the function of like sharing the screen. What can we do with a shared whiteboard together? So it should be in steps. You cannot give that all in like one time, because then you would really threaten or increase the risk for a client to just not show up and not engage or disengage from the client. So I think a lot of really walking through, probably it could be a pre-session, walk them through like each step. This is how it would look like. How does it feel for you? What can we do to, improve your privacy? Are you uncomfortable having, people in your family around you? Probably we could have like a virtual background. I'll teach you how to create a virtual background. So at least, I don't see what's going on like at your back, things like that.
Yep. I can't hear you, Jennifer.
Yes, we can't hear you, Jennifer.
That constant process of needing to press that button so that I'm off mute.
Telehealth in
I don't
action.
know if I'll ever get over that. I know.
I think the good news is
Jennifer,
we've all come to accept it.
Yes.
We've all accepted that that's
exactly.
going to happen.
Exactly. So Jennifer, one of our participants wants to know if they're using a short assessment form, can they have multiple sessions, or does it all need to be completed in one session?
So there's nothing in regulations that say it all has to be done in one session. I'll kind of start there. Certainly here in LA at our agency, we do not require everything to be done at one session. I think that's typically what was done pre-COVID, but certainly was not a requirement. So I would check with your agency on this because sometimes agencies have different rules, but certainly nothing in regulations say you have to do it all in one session. And I would actually encourage people to feel like you have the flexibility to do multiple sessions with assessment right now.
Great. Richie, this is one that also has come up on a number of our different webinars. You talked at the beginning of your presentation that you're actually seeing a decline in the no-shows in your organization. However, many of our participants are actually finding an increase in their no-shows, and this is continuing. So what are some of the things that you're doing differently? What have you done that you feel is effective in being able to decrease your no-shows?
I think it's really finding what's the story behind the no-show. And sometimes it could be misinformation or stereotypes around like using telehealth. Like probably in like clients, if you are pitching it the first time, oh yes, we're going to do our sessions purely using telehealth via phone or video conference. And probably for some clients, they think, oh, that's not going to work. I really see like they really view like therapy as working if it's done in person. Like really a dot of like psychoeducation. Like I know a lot of evidence practices out there have really come up with studies and comparing like in person versus like telehealth. And it seems the outcomes are very comparable. And that's good for the client to know. And I think part of it too is, the first session is very critical in terms of like engagement. What do you do on a first session with the client to really demystify what they know around like telehealth and a lot of psychoeducation of how it has worked for many clients. I think that's part of that in terms of like engagement. Because sometimes like knowing the reason, a client may not show up and we may not know until we ask their story. What's their story behind? Why are they not showing up? Probably it's something that you haven't figured out, like in terms of, I'm really scared to show up. We're in, it's an issue of privacy that they would see my home. Like again, I talked about like creating like a virtual background. Probably in the beginning, start with a phone conversation first. So it's more a client may feel less anxious about it rather than jumping immediately to like a video teleconference with the client. So I think those are like important tips on how to do it, like navigate it very slowly with the client.
Great.
We've in LA, we're kind of reaching out prior to the session to get individuals comfortable and kind of prepared for what to expect. So I think the more that somebody knows what to expect, the more comfortable they're going to be. So some of that might help with some of the no-shows because it might be a little bit daunting to all of a sudden you have a visual contact with somebody that might be uncomfortable for some people. So giving them that information beforehand could be helpful.
And Jennifer, this question has also come up on a number of our webinars. Do you have any suggestions about when doing telehealth? Do you think a mixture of Zoom and telephone would be a good way to be able to kind of maintain engagement?
Yeah, I think certainly. I mean, I think right now you go where the client is at and what do they need. I think a lot of clinicians were uncomfortable doing particularly assessments over the phone. In LA, that was not actually something we allowed at all. I mean, we really felt you need to have that visual contact of somebody in order to assess and diagnose them. So a lot of people were really clinically just uncomfortable on their own side, not even just client side, but on their own side were very uncomfortable with that. And we had to do, a little bit of level setting of right now. It's a whole different, scenario. And so if telephone is the best that we can do right now, that's better than not doing anything. And I think we need to remember that piece of it.
Very important. Richie, this one is interesting. So we have a participant and they are trying to do an intake and the person that they're working with is over 18 and the parent wants to be present during the intake, but the actual client being served doesn't feel comfortable. Do you have any ideas on how to be able to manage that situation?
I think for me, if the parent or the caregiver really wants to be part of like the assessment, probably stage the sessions in such a way. Yes, we will have like a dual session wherein both of you are present. But probably in the beginning, I really want to hear the story first from the perspective of the youth, and then from the perspective of the caregiver after. And if both are amenable, then have like a joint session wherein the caregiver is there. That's one thing I can think about, because I think it's really also an opportunity for when you're meeting with the 18-year-old youth, like really asking what are your apprehensions about having your caregiver there in the room with you. So at least then you can prepare that particular client before the joint session with the caregiver, like, okay, I would be limiting my questions to this. So at least the client is like prepared on what to expect. Because again, it's like demystifying it. Probably there's a lot of anxiety about, I really don't want my mom or my dad to hear about my substance use, certain things that I hold really private for me. And being 18 too, I mean, he has the right for that privacy.
Exactly. Perfect. Thank you. So Jennifer and Richie, thank you so much for your time. I can see by all the questions that came through while you were speaking that there's high level of interest, and many, many thank yous from our participants for your clarity. That was what people kept remarking about. I also want to be able to thank the California Healthcare Foundation again for sponsoring this webinar series. And then I really want to thank all of you for attending. The questions are always pointed, and I can see that there's real interest in being able to improve skills in behavioral telehealth. And so thank you so much for being able to be here. I'm going